Good afternoon, everyone. On behalf of the VCCC, I'd like to welcome you to our 2021 Head and Neck Symposium on Intimacy and Sexual Health. I'd like to make an acknowledgement of country and to acknowledge the traditional custodians on the lands on which myself and today's presenters and audience are located. I would also like to pay respect to elders, both past and present, and extend that respect to other Indigenous Australians present online. I'm David Wiesenfeld, and I'm very grateful to be able to arrange a segment such as this, a symposium such as this, with the support of the VCCC. In my lead role, I get to arrange educational programs that I think are needed and the community think are needed for head and neck. I'm also grateful for the collaboration and opportunities that grow through the VCCC and through the broader cancer community that we are in contact with. Next slide, thanks. We've got presenters today, and I want to pay my thanks to the organising committee, all of whom have worked very hard to make sure this meeting runs well. Professor Jane Hocking, Miss Gretchen Fox, Dr. Lachlan McDowell, and Jasper de Boer, who's the brains behind the event. And a special thanks to Jane and Lachlan, who are the instigators of this meeting. The objectives of today's meeting cover different themes. A major theme surrounds the importance of sexual health and intimate relationship in head and neck cancer survivors and how it may be affected by head and neck cancers and their treatment, an impact that is largely overlooked in our head and neck surveillance clinics. Importantly, this will be through the voice of head and neck cancer survivor and advocate, Julie McCrossan AM, who will be well known to many of the audience. The patient experience will be complemented by clinical research presented by Dr. Rachel Dodd from the University of Sydney and Dr. Lachlan McDowell, radiation oncologist at Peter Mac. Associate Professor Julie Brotherton, a public health physician and medical director of the VCS Population Health, will provide the audience with an update around HPV transmission as it pertains to head and neck cancer, an important area and intimately related to sexual health and intimacy issues, as patients' concerns about HPV transmission can lead to distress within patients' relationships and changes in their sexual behaviour. Maria Furtado, the head of clinical psychology department at Peter Mac, will provide an overview of psychological interventions that are available and recommend local referral pathways for sexual health, relationship and intimacy issues that our patients may face. Dr. Nadia Rosen will provide an overview of the activities and information available through head and neck cancer for survivors and their carers. And the speakers will be joined by Professor Jane Hocking, an epidemiologist from the University of Melbourne, and patient survivor Gretchen Fox for a panel discussion to follow the individual talks. Next, thanks. We have got a question section, and you either use the chat or the Q&A function, which will bring up the opportunity to raise questions. Next slide, thanks. We are recording this meeting and it will be available for you to view again on the VCCC Open Learning page, viccompcancercentre.org/learn. Next slide, thanks. If you're having trouble getting on, you can email any of us in the organising committee to ask for help. So we have conducted a survey of head and neck practitioners to better understand their abilities and concerns in managing patients. A minority of practitioners were confident in managing or referring patients who had sexual health issues. Practitioners had a good understanding of the etiology of HPV-related head and neck cancer, and there was strong support for CME opportunities on the subject. Here you can see two graphs demonstrating the response. Do you think head and neck cancer and its treatments have an impact of a patient's intimacy and sexuality? Most people thought there was a lot. So we identified it's an issue. Do you ask your head and neck cancer patients about the impact of cancer on their relationships with their intimate partner? Hardly ever, because the doctors are not well versed in this area and they don't want to tackle patients' intimate problems. So I think that's a barrier to us that we want to try and overcome through education. Next slide, thanks. Head and neck practitioners are not well prepared to assess and guide patients, many of whom we expect have difficulties with intimacy and sexual health related to their head and neck cancer and its treatment. The disability of head and neck cancer and the treatment that we provide is immense, and we are well aware of the suffering that patients have through their disease and through their treatment. Patients with HPV-related head and neck cancer are challenged by the concepts of etiology and the risks of transmission. And we want to present clear information and strategies that enable practitioners to guide patients. Thank you. Next slide, please. So our goals today are to contextualise the impact of head and neck cancer and its treatment, the effects on sexual health and intimate relationship among survivors, discuss the importance of sexual health in survivors of head and neck cancer, explain the common patient questions about HPV positive head and neck cancer and provide the knowledge to answer them, and discuss existing frameworks for addressing sexual health issues and the opportunities and barriers in implementing strategies to improve intimacy and sexual health after head and neck cancer treatment. Thank you.
Julie, it's all yours.
Hello, ladies and gentlemen. I'm so sorry. I thought there was going to be an introduction. My name is Julie McCrossan, and as the slide indicates, I'm a survivor of head and neck cancer. Look, I just want to begin by saying thank you so much for organising this symposium. And I'm not discouraged by the data that we've just been given by David, because I've lived long enough to see tremendous change in difficult areas. And I'll start with a quote: "Miraculous changes happen apparently overnight, and they're based on days, weeks and months of longing for something better." And underpinning my remarks is the belief that a very significant majority of head and neck cancer patients are longing for help to return to emotional well-being and connected to that a sexual life and an intimate life. So I believe that many head and neck cancer patients need your help to return to a happy sexual life, because we are the walking wounded. We are damaged emotionally or physically or both. And our partners are traumatized too. You know, for many of us, it's predominantly an outpatient experience. And if we're lucky enough to have a partner, they've watched us go through something absolutely extraordinary. So what I'm asking you to do, my call to action at the start, is I want you to band together and to fight for the money that you need to give us the help that we need. And because we need you, the teams that saved our lives, to stick with us and to help us manage the side effects for the rest of our lives. We need you, our multidisciplinary teams, not just in the acute phase and in the checking for that 5-year period. We need you after 5, after 10, after 15 years. And most importantly, we need quick access to dentists who truly understand what they can and cannot do to us, specialist nurses and psychologists. So I'm going to introduce you to 3 patients, and I want you to listen deeply as if you've never met a head and neck cancer patient before. So if you're familiar with this, try to listen deeply in a different way today. And I want you to ask yourself as you listen, if this happened to me, how might it affect my sexual life? If I looked like that, how might it affect my sexual life? If I felt that way about myself, how might it affect my sexual life? And if I needed the kind of treatment that does this to us to save my life, try to just have a think about what kind of help might help me, help you to kiss and have sex with your partner again once you're well enough to consider that. The first patient I want you to meet is me. After my first radiation treatment in mid-2013, so that's nearly 8 years ago, I came out of the bunker and I just ran into the toilets because I didn't want my partner to see what was happening to me. And I just sobbed in the toilets. I got myself together and I got out into the car park, and then I broke down in the car. And I had another 29 consecutive days of treatment after that, and I didn't cry again. But it's more accurate to say to you, I couldn't cry again, because I haven't been able to properly cry since I was treated on that first treatment day. I haven't been able to cry in that way that you get a bit of release for nearly 8 years. You know, I've had a slight moistening of the eye, so I know my tear ducts work, but I haven't cried. And I guess what I'd sum it up as is something has frozen inside of me, and my sexuality is frozen, and there has to be a connection. The research, the little of it I could find, indicates I'm not alone. Yet no one in my cancer team has ever spoken to me about it or raised the issue. And they're a caring and professional crew. They just haven't raised it. So why does this treatment damage our emotional lives? And what can we do? And I say we because I work in close partnership in a myriad of ways with multidisciplinary clinicians to try to make a difference for my fellow current and future patients. You know, what can we do to make psychological pain relief as much a routine part of care as physical pain relief? So here's my story.
So my name's Julie McCrossan, and I'm a former radio broadcaster and television presenter with the ABC and Network 10, and a print journalist. Just over 5 years ago, I got the diagnosis of stage 4 cancer in my tonsils, tongue and throat. I'm alive over 5 years later. I can speak and I can swallow. I am pro-radiation therapy. But what I found really traumatic was the immobilisation mask, as they're called. I'd prefer to call them a safety mask. I can remember vividly the first time that I was clipped down firmly in the big green mask, because I immediately panicked. I felt my heart rate go force 10. I went red in the face and sweat started pouring off me. And I immediately said to the radiation therapist who'd clipped me down, "Please take it off. Please take it off." To their credit, they whipped it off me. But I remembered that there were about 25 people waiting outside. I remembered that my surgeon had told me I was not eligible for surgery. I had to cope with radiation. So I literally thought, suck it up. And I said, put it back on. But it was just a desperately difficult and panic-stricken experience. And to panic for 20 minutes is a really remarkable thing. If it is possible, through research, to find an alternative to the mask, to remove the mask and keep us safe, I would love to live long enough to see that happen.
Well, I'd like to introduce you now to Maureen Jansen from New Zealand. Maureen helps to run a registered head and neck cancer charity for fellow survivors, and it's a totally voluntary proposition. It runs a support network with a newsletter, face-to-face meetings, and a Facebook group. And as you listen to Maureen, please ask yourself, if I needed the treatment that Maureen has had over the years, what kind of support might help me to have the confidence to kiss and to have sex with my partner again? So here's Maureen Jansen.
Maureen Jansen from Head and Neck Cancer Support Aotearoa, New Zealand again. Julie has asked me to talk about mental health and head and neck cancer. And I could go on about this for ages because I've had 3 bouts of head and neck cancer, getting more disfigured and disabled each time, but still here. And I have boiled down my thoughts as a long-term patient on mental health issues And I've come up with 3 things I think are important to me as a patient and to carers who live through this situation with their spouses, partners, etc. The first one is medication. I don't know if all patients realise that there are useful medications that can reduce the pain, the grief, the anxiety and the fear and the panic. There are anti-anxiety medications, which I have never been offered, never taken. Fortunately, I probably haven't needed them, but antidepressants have served me very well indeed, to citalopram, to keep me thinking a bit more positively, not being in that dull, aching, panic, anxiety-ridden mode long term. I think they've helped together with my second piece of advice or strategy, which is seeing a counsellor, a psychologist or a psychiatrist. I don't know if all patients, especially men, accept that this is just a practical, helpful aid to coping with a cancer that is so isolating, disfiguring, has such terrible treatment over many weeks that can leave you pretty emotionally scarred. So I think that normalising psychological help is a very good thing. It's happening now. It can't happen fast enough. My third method of dealing with the grief, pain, depression, anxiety of head and neck cancer is peer support. This is maybe should be top of the list. When I first got head and neck cancer, I was so worried that I'd be so disfigured, or so disgusting that I'd be isolated, my life would be over even if I survived, that I joined the Oral Cancer Foundation in America, and they helped me hugely. A big pool of experienced patients, some of them with excellent peer support skills, and tons of information. And now we have the Aotearoa group, a Facebook group, and for all Facebook sins, this has been a great group for me to help manage, because it's not only getting support from your peers, but giving it that helps ease the troubled soul. So those are the 3 things that I've boiled it down to for dealing with mental health issues, and there'll be many more, and they don't work for everyone. But I hope that gives some focus for discussion. Thank you.
Thank you very much to Maureen Jansen. And I don't know if you're aware, but because most of us get ejected from the mothership, which is how I think of my hospital, my cancer centre, after the 5 years we're ejected. And as you all well know, our side effects, whether physical or psychological, are likely to increase as the time goes on. And so we look for each other, and there is a huge number of Facebook groups, many of them run by very responsible people with an evidence-based focus and protocols to ensure that it stays evidence-based and rational, and that's implemented. But, I spend my life posting these little videos I create with in partnership with clinicians in order to put some really good quality, up-to-date evidence into the mix. And it's because we've really been abandoned. That's what it feels like. But let me introduce you to Hans Eade from Camden in New South Wales. People often talk about men being unwilling to ask for help or to receive help, and Maureen made reference to it. I have a vivid memory of being an MC at a prostate cancer forum at the Peter MacCallum Centre in Melbourne. And there were an audience of over 200 prostate cancer survivors and their wives, and there were over 40 specialist prostate cancer nurses. And I witnessed for the whole day in my emceeing role just how relaxed those men were with the nurses together. And they were talking about different ways to have erections and how to manage incontinence, but they had this relaxed, professional, engaged relationship. So different from that startling never on the research we saw before about raising these questions of sexuality. So when will head and neck cancer patients have a network of skilled specialist nurses to help us. I know there are issues around giving them a career path. Surely we can make them head and neck and lung cancer nurses, because as we know, that often goes together. And the lung cancer people are crying out for help as well. But anyway, here's Hansi.
Oh, I'm Hans Eve. I'm 64 years old and living down in Camden. And this is Sisal. I was diagnosed for cancer in 2011 when they told me that I had to have an operation and then after that radiation. So the first thing was to make the mask, the dreaded mask, like one of them. When the treatment started and they asked, do you want to have something for it to calm your nerves and things, and of course being a man you say, oh, I'll be right, but I knew I wouldn't be 100% right because I'm claustrophobic, so 25 to 30 minutes that you're strapped down and you can't move, it was horrendous. It was dreadful, but I can take a lot of things. I just learned to have happy thoughts and to try to be not there, to be somewhere else and get over with it. And after that I recovered and I wasn't a nervous wreck, that's not the right thing to say, but I felt very uncomfortable to be in confined spaces after that as well. And then recovered and went back to work and life was pretty good again. 2 years later the cancer came back on the other side of my neck. So we had to do it all over again. I would have been in for a couple of minutes and I was waving my arms madly. I said, I can't do this, and I come back out again. So then they had to give me a sedation and had to wait then half an hour for that to take place and things and try it again. So that was pretty traumatic. But then I heard that a lot of people need to be sedated every time. 2 out of almost 60 treatments, I freaked out. But I did it, and I'm pleased that I did. I've been cancer-free for 5.5 years now. So in my book, I'm cured.
We don't have time here to talk about the research that's being done at the Imaging Institute at the University of Sydney to find an alternative to the mask, but it's been funded by Cancer Australia. Professor Paul Keel and his team are doing it, and it all resulted from him hearing me speak at a conference. So that to me is a marvellous example of how quality research can arise from an engagement with patients. But look, as I said, I have the greatest respect for my cancer team, and I've been there many times, but no one has raised intimacy and sexuality. And you need to raise it. It's hard for us when we're waiting outside and everyone's always running late to sort of wave and say, there's something else I need to talk to you about. It needs to be routinized. So problems with intimacy and sexuality are not only about facial damage, dental damage, jaws that can't open properly, and of course the dreaded dry mouth. Of course, physical damage is challenging and we do need help long term. But I guess my message for today is that damage can be emotional as well. And my final video is with Associate Professor Haryana Dhillon, who's a survivorship researcher at the University of Sydney. So here's Haryana.
Do you think our health system gives equal attention and care to the emotional impact of cancer as it does to the physical?
Yeah, it's a great question, Julia, and I think the short answer is no. So we're very focused on disease sites and the diseases that people have and where that happens in their body, and we're not looking at that as a whole of system problem, and really that's the impact of the illness on people emotionally, on their lives and how they live them. And I think, you know, we really need to look much more holistically at how different illnesses and treatments have an impact on everyone's all of everyone's life, all of those aspects, and they're all equally important to the person living with the illness.
Just two quick comments. If I could ask our host Jasper to pop up a photograph of my teeth. If you're able to whack that up, Jasper. So I'm the daughter of an orthodontist, and I know you know we have dental problems, but you don't really know because you don't see us much after 5 years. I believe the failure to include the mouth in dental care is a human rights issue, and it's certainly a human rights issue for head and neck cancer patients. I've spent thousands. This is my dentist just showing me the next thing he's going to do to me, and there's some work. That's one of my x-rays. There is thousands of dollars in those shadows, and if I'm lucky, I'll live long enough to spend thousands more on my mouth. How do you have romance? You've got to be able to smile, kiss, and have dinner together. This is the essence of dating or of keeping your marriage alive. And you need teeth for all those things. And the fact that we're still doing full mouth clearances, what a horrific expression it is, or taking 6 to 8 teeth out, because a judgment call is made that people won't be able to afford to look after their teeth later is shocking. We need you to help us get a special allocation to head and neck cancer patients for dental work because it's connected to cancer treatment. And I'll just show you a second quick final photo that's only 24 hours old, and I'll read it. This is a Facebook post, a young mother. You can see she's had her surgery, and her message, 20 radiation and 4 chemo treatments left after removing a golf ball sized tumor from my neck. It's starting to get really rough, and I have a 6-month baby girl I'm fighting for. So this is on one of the 8 Facebook sites I'm part of. I'm in a constant connection with patients at every point on the journey, because a lot of us older survivors help the others. And these 2 young women, this young woman who gave me permission to show that I've been communicating overnight, was communicating on Facebook with another mother with a baby, both in treatment. What's my point? It's not just old people who need psychological help to have a sexual life. But I put it to you, fellow baby boomers, I dye my hair, I'm sure you do too. Old people need sexual help too. We want a sexual life. So thank you, and I look forward to the panel.
Thank you so much, Julie, for this. And the next speaker is Rachel Dodd. She's a research fellow at the School of Public Health, University of Sydney, if I'm correct. Yeah, thank you so much.
Oh, sorry. Thanks so much for that, Julie. It's really important to keep those patient stories in mind, especially as we talk through with this seminar. So as Jasper said, I'm a postdoctoral research fellow at the University of Sydney, but the research I'm going to talk about today is actually from my PhD research, which I conducted in the UK at University College London, which was funded by the Medical Research Council there. So for my PhD, I was examining the psychosocial impact of human papillomavirus in oropharyngeal cancer. So just to give you an overview of some of the studies, the studies that I did during my PhD. So I conducted a systematic review. I also looked at some of the coverage of HPV and oral cancer in the UK media, particularly after Michael Douglas had disclosed that his throat cancer was caused by HPV. I also did an interview study with some health professionals, followed up by a quantitative study with health professionals, and then also an interview study with patients and their partners, and then finally development of some information materials. So there's 2 distinct dimensions associated with HPV and head and neck cancer, which are important to consider in the communication of HPV and head and neck cancer. And one is the move from the traditional causes of tobacco and alcohol to a sexually transmitted infection, and also the improved prognosis compared to HPV negative cancers, which have a greater average 5-year survival rates. So prior to starting my PhD, it was important to look at what had been done in the cervical cancer context. And with Kirsten McCaffrey's study, which I'm presenting the results for here, she found that testing positive for HPV was associated with adverse social and psychological consequences with women related primarily to the sexually transmitted nature of the virus and its link to cervical cancer. So this included women saying that they were shocked, anxious and distressed about their diagnosis of HPV. They were concerned about sexual relationships and future transmission of HPV, and also said that they were worried about disclosing their HPV result to other people. This also caused women to question the fidelity and trust in their relationship, and were also concerned about future transmission to partners, whether it be at their current partner or any future partners, and also the shame and stigma associated with the sexually transmitted nature of the infection. And then this is just a quote from one of the women that Kirsten McCaffrey interviewed, and just really saying how she felt stigma about the STI. So women also reported in this study receiving inconsistent information from health professionals, which contributed to their confusion and distress about the HPV infection. So head and neck cancer is often described as highly traumatic because of the facial disfigurement and dysfunction of the upper aerodigestive tract associated with its treatment. And as Maureen touched upon about the disfigurement, the disfigurement caused by treatment can lead to isolation from family and friends. And one study interviewing patients found that over half had been stigmatized or discounted because of their appearance. So disfigurement can be stigmatized independent of HPV. And then of course, there's also the additional concern of transmitting HPV to partners. So my qualitative study with health professionals in the UK, really the key messages that came out of that study were to try and minimize the negative psychological consequences of talking about HPV. And really the key points in normalizing HPV included talking about the high prevalence of HPV. So really talking about the fact that anyone who's sexually active will have been exposed to HPV. Also making sure that patients were aware that it was normal sexual behavior. So it was not in any way an indication that the patient had been promiscuous. And also by linking it back to cervical cancer and the HPV vaccination really helps patients understand that it was the same virus involved in both cancers, so that this wasn't anything special. Then if a patient was worried that they'd caused their cancers, participants would reassure them that there was nothing that they could change in their behavior that would have affected the outcome. And then also telling patients they had a better prognosis than HPV negative patients. It was seen as a bit of good news for them. And the results of this can be found in a publication with the reference down there at the bottom. So I really wanted to also present some of the results from an interview study which I conducted with patients and their partners. And very few studies have been conducted exploring the impact of being diagnosed with HPV for both patients and their partners. So it's important to explore the experiences and beliefs of the partners as well, because previous research has found that different experiences of illness and treatment in the partners compared with the patients. So this was an interview study with patients and their partners. So I interviewed them individually, and we used face-to-face interviews where I first asked them about their experience of being diagnosed or of their partner being diagnosed. And the interview was prompted on what the participants said in response to this first question, but I covered symptoms, diagnosis, any psychosocial impact, and any information needs as well that they had to do with their diagnosis. So recruitment occurred in 2 different areas of the UK, in Liverpool and Brighton, and all participants were at least 1 year post-diagnosis. And this paper has also been published as well, the reference there below, so you can read more about this at leisure. So this was just some sample characteristics of who I interviewed. So of the patients, there was 20 patients and 12 partners that I interviewed. And the majority of those patients were male, white British, married or had a partner, with a mix of employment or being retired. And of those that I interviewed, there was only 12 that actually knew that their cancer was caused by HPV. So I wanted to present some of the reactions and people's thoughts on HPV. And this top patient was talking about the fact that they hadn't been told by their clinician, but they received some information about a study which was based on the fact that they'd been diagnosed with cancer that was caused by HPV. And then as they were reading this information, that's where they started getting a bit of understanding of where it's come from, which they say here, which is a bit embarrassing. And this same patient also said, you know, it's not the sort of thing that I can discuss with my wife. And then another female patient that I spoke to who didn't have a partner, and she really relied on her daughter for support. She also said, it's not really a conversation that I want to have with my daughter. And then this other patient just kind of put it down to being in the wrong place at the wrong time. And then there was also some patients that weren't really concerned about the HPV, and they just wanted to get better, and they were relieved that the fact that it was HPV related meant that the prognosis was better. So this patient here says it wasn't a concern really, you know, just I felt happier when it said that the prognosis was much better. You know, the people that have HPV related oral cancer do better. So there was also some patients that were quite bemused by the fact that HPV was mostly sexual, because this top patient, you know, she thought it was, you know, she'd only had 4 partners in her whole life, so she was quite bemused by this fact that it was you know, a sexually transmitted infection. And then there was other partners also that just completely dismissed, you know, this partner at the bottom who said, you know, friends made a joke about it, it could be done. It's something that's often caused by oral sex or something or other, but that's a load of nonsense in his case or something or other. So other than that, no, absolutely no idea of how or why or anything. And then just finally, this was some of the concerns that, that patients and partners expressed about transmission of HPV. So this patient at the top was concerned about passing it backwards and forwards between him and his wife. And then also this other patient was wondering where they'd actually got HPV from, whether they've got it from his wife or whether he'd got it from a previous partner. And then also just kind of questioning if there was other ways that you could transmit the virus other than through sex. So, you know, could it be a cut on your hand? Could it be a kiss? It could be anything really. Thinking that really they were under the impression that they still didn't really know. So then just finally, I just wanted to touch on some of the questions that kind of came out from patients during my PhD. So these are just some of the questions that, and some of the information needs that that patients expressed. And these have been, we've sought to develop an information resource which we're actually currently just evaluating at the moment. So these are just some of the questions that we've tried to cover to help patients and also clinicians communicate with patients about these questions. And thank you very much.
Thank you so much, Rachel. That was fantastic. The next speaker is Dr. Lachlan McDowell. He's a staff specialist at MacCallum Hospital, specializing in treatment of head and neck cancers.
Thanks, Jasper. Sorry, it's just only letting me. Okay, thanks, Jasper. And I'll follow on from those 2 excellent talks we've had from Julie and Rachel today, and we'll hopefully address some of the similar issues that Rachel raised also came out in our study. So the title of my presentation is Sexual Health Outcomes and Changes in Interpersonal Relationships Following Chemoradiotherapy for HPV-associated oropharyngeal cancer. The results from this study have been published online in the Red Journal, and more comprehensive data that I'm able to present due to time constraints today is available online. There are no ethical or financial disclosures that I need to make. I would like to add that I'm not a sexual health expert, and really the primary interest I have in this has really been sparked by frank and open discussions that I've had with patients over the years, and my observation, this is a big problem, and it's largely unaddressed in current survivorship models. The study was designed with the primary aims of reporting sexual health, self-reported changes in patients' relationships, and measuring fear of cancer recurrence. Today, I'll focus primarily on the two former objectives. And we also collected a number of other PROs, which we aimed to correlate with the primary endpoints of interest. Eligible patients, this was a cross-sectional study. All patients were HPV oropharyngeal cancer survivors who were more than 12 months following completion of treatment and recurrence-free at enrolment. Overall, despite the sensitive nature of the topic, we actually found that patients were very interested and engaged in the topic, and we had quite a high rate of patients accruing to the study. Of the 146 patients that we approached in clinic to enroll, 136 of those patients consented and completed the study questionnaires. The patients that were included and enrolled were the typical demographic. These were, it was a largely male population. They were patients diagnosed in their mid to late 50s. And the 72% of patients were in partner relationships at the time of enrollment. Only very few patients in this study identified as non-heterosexual. And interestingly, in keeping with the data that Rachel has presented, only half of the patients, when asked about whether their cancer was caused by HPV, were able to confidently say that that was the etiological cause of their cancer. We requested baseline relationship or marital status and then any changes that had occurred at the time of enrolment. The mean time from completion of treatment to enrolment was about 3 years. There were 10 patients who reported a change in their marital status, and of those, there were 6 partnered patients who reported that following their cancer diagnosis, they separated or were divorced from their prior partner. We asked patients, had their relationship changed since their cancer diagnosis and treatment? We found that almost all patients responded, and those who didn't respond were non-partnered at both time points. 57% of patients indicated that they had no change in their baseline relationship. And of those patients who indicated that there was a change, the majority of those patients actually indicated that the change was positive. In the interest of time, I've not presented any of the representative quotes that we had from patients in today's presentation. However, this is available on the online paper that I provided the link to at the start. Positive and negative dyadic coping were the major causes of relationship changes following the participants' cancer diagnosis and treatment. While some relationships were strengthened through supportive spousal behaviours or increased cohesion or bonding, there were a number of patients whose relationships were weakened through poor communication and unsupportive spousal behaviours. Lack of sexual desire was also mentioned either by the partner or their I guess perception of their partner's interest. And benefit finding was also mentioned, and this is where the respondent experiences positive growth as a result of the adversity, I guess, of their diagnosis and treatment. We asked a similar question with regards to how patients' sexual relationship had changed. Had a similar number of responders, and while 50% of patients indicated no change, there was a much higher proportion of patients reporting a negative change in their sexual relationship than they did with regards to their general relationship. When sexual dysfunction, especially erectile dysfunction, a lack of sexual desire, and treatment-related symptoms, most notably fatigue and dryness of the mouth, were major causes of changes in patients' sexual relationships. I'd like to also highlight the HPV transmission as a minor cause of this change. And although this was only in 4 patients, there were significant changes in those patients' relationship. We identified one patient who held a significant degree of resentment towards his partner who had previously positive pap smears. And there are also a number of patients who had, 3 patients in total, had concerns about fear of future HPV transmission, which led to changes in their sexual behaviour. We also collected sexual health outcomes, and we collected this using what was at the time a newly developed module from the EORTC Quality of Life questionnaire suite. This questionnaire measures physical, psychological and social aspects of sexual health and includes a sexual satisfaction item as a composite score from 8 of the items. While the usual way to present these scores is that even the individual scores are then rescaled from a score to 0, 100, I think it's actually a bit easier to present these in the raw format. When there were 60% of patients who indicated that an active sex life was either quite a bit or very important to them. However, only 20% of patients had reported being quite a bit or very sexually active in the last 4 weeks. Importantly, when patients were asked about their levels of satisfaction with either their level of intimacy or their sex life, over 50% of patients responded either not at all or a little. When we asked patients, when the questionnaire asked patients whether they thought that the treatment was the primary reason for affecting their sexual activity, only 20% of patients attributed that this was a significant cause of their a reduction in or their current sexual activity. And this sort of kept with the textual data in terms of how many patients reported, I guess, physical symptoms as a consequence of their treatment. Importantly, almost all patients reported that they had never had any communication about sexual issues with a healthcare professional. We did do a comparison between male and female responses. We only had very few female participants, only 22 out of the entire cohort. But they did less frequently report an importance of an active sex life and also reported lower rates of recent sexual activity. The sexual satisfaction item, the mean score for the entire group was 47. The variation was quite wide. This ranges from 0 to 100, with 100 being the best possible score. There are a number of, this is actually quite a low score for most of the URTC modules. There are a number of factors which were fixed that were associated with worse satisfaction, and lower rates of sexual satisfaction were reported by females, those patients with a higher burden of medical comorbidity, and those patients who were longer since chemoradiotherapy or radiotherapy. Patients who rated sex life as more important or reported a higher security in their relationship, or for males, those patients reporting a higher confidence with obtaining or maintaining an erection, reported higher rates of sexual satisfaction. And it was surprising that although we hypothesized that a number of other factors would be associated with rates of sexual satisfaction, none of these were significant on a univariable analysis. And these include things such as age, treatment intensity, the extent of toxicity, whether reported by patients or clinicians, and quality of life, anxiety and depression, which is something that is often frequently reported in other series. There were some similarities and also some differences between this cohort and a cohort of nasopharyngeal cancer patients who I had previously looked at. And these are a group of similar patients. They're younger with virally mediated head and neck cancer. In that series, sexual satisfaction was associated with quality of life and emotional distress. And we also identified that it did correlate with some head and neck symptoms, such as the extent to which taste had been affected. The limitations of this study, it's cross-sectional data, sexuality, and intimacy, and those changes are complex, and the absence of baseline data is certainly a major limitation to the data. The patients were all assessed at different time points on their cancer journey. The relationship questions were asked through the perspective of the patient and were not corroborated with their partner, which is, I guess, it would have been interesting to capture their experience. There is underrepresentation of females in this group, and also almost all patients identified as heterosexual. And there's not at the moment any normative data for these sexual health outcomes available. And I'd just like to make a final point and finish on this, that we are following up this study with a prospective study evaluating sexual health in this cohort. This study is accruing at Peter Mac and Genesis Care at St. Vincent's in Melbourne. And we've only had the study open for 3 or 4 months, and we're almost halfway, 40 out of 100 patients. We've had very few people decline enrolment, and only 1 patient on account of the topic. The primary objective will be to describe the course of sexual health outcomes before, during, and after treatment, and to examine some of the predictors which may account for the variations in sexual satisfaction and how patients rate the importance of sexual activity in baseline and at 12 months. The secondary objective is also interesting, and that it will be how patients prioritise preservation of their sexual function at baseline and at 12 months. And I'm doing that using a modified version of the Chicago Priorities Scale. So this is a validated way to assess the priorities that patients may have, including curing their cancer and other general outcomes, such as having normal energy, but also head and neck specific toxicities. It'll be interesting to see where preservation of sexual function falls in those list of priorities, but I can tell you that having done some of these, that there are patients who are prioritising their sexual function in the top third of their priorities. So I'd just like to thank, this has been a great opportunity to present this data again. I'd be happy to take any personal correspondence if it was if further information or was required, or it was of interest to any members of the audience. Thank you.
Thank you, Lachlan. That was very interesting. I would like to introduce now Associate Professor Julia Botterman. She's a public health physician, epidemiologist, and medical director of VCS Population Health at the VCS Foundation. Thank you very much.
Thank you so much, Jasper, and thank you very much for having me here today. I'm just going to share my screen with you now. Okay, so we're going to dive right in to talk about some epidemiology of HPV, or human papillomavirus. And I guess we heard very much from Rachel's earlier presentation that one of the things that's quite helpful is to think about the fact that having HPV is actually a pretty normal part of the human experience. And certainly in the area that I usually work in, which is in HPV vaccination and in cervical screening, we now have HPV-based screening, which means that every woman who tests positive knows she has HPV. So this is a conversation that comes up again and again. And of course, HPV, I saw there was a question in the chat about this. There are about 40 types that very commonly infect mucosal surfaces of human beings, and that's all they do in life is go around infecting us. And about 12 of these types, unfortunately, if they persist in our cells, usually over many decades can lead to cancer. And unfortunately, we don't know who out of all the people, most of us who are exposed, will have that trouble with their immune system clearing it and developing that persistence. These are incredibly sneaky viruses. But most of us will have HPV. It's a very normal part of being a human being, and most of the time we never even know it. And I particularly like this modelling paper from the US, which is why, as an epidemiologist, I can't resist numbers and tables to show you. But this study, I think, is really interesting because what they've done is had a look at how transmissible the virus is, what we know about its characteristics, and the way the population mixes together and the average number of sexual partners people have. And you can see that they've estimated that for those who have at least one opposite sex partner, the average chance of getting HPV in your lifetime is around 85% for women and over 90% for men. And I've just put in a shot of the table here, and I wanted to emphasize this first group here. Even those people who only ever have one sexual partner, they're estimated have almost a 50% chance of having HPV. And I think this is very interesting, and I think we find it a lot that people say, well, I've never been very sexually active. How could it possibly have affected me? but it's almost like having sex and HPV go hand in hand. So I think that's a really great place to start the conversation. We can change the slide. And yes, in Australia as well. So this is now looking at a seroprevalence study that we did way back just before the HPV vaccine program was being rolled out. And we wanted to know how many people in Australia had been exposed to just four of the 40 types that are in the HPV vaccine. And even though a lot of people don't make an antibody response after they've had the virus, it's about 60 to 70% of people, you can see that by middle age, both men and women, 30 to 40% have just one of these 4 types. So absolutely, it is extremely common in Australia as well. Now, what about in the mouth? Now, this is a lot more tricky, I have to say, and that's mainly because there really hasn't been a standardised way of collecting samples in the mouth and testing them, and people then interpreting what it means. Does it mean that you put your finger in your mouth and you had HPV, or that you were exposed last night, or does it mean that you actually have an infection producing the virus in your mouth? We don't really know. But this is a massive regular population study called NHANES that they do in the US in 2-year blocks. And this very recent paper synthesised 3 serial intervals of this study that measured, using an oral rinse, the detection of HPV in people's mouths. And on this graph, you can see on the left-hand side there, that's the female results, and on the right-hand side, it's the male results. You'll immediately see that there's more oral HPV found in men, and this is a very consistent finding around the world. The lighter part at the bottom is those types of HPV that are associated with cancer development if you have them over a long time. So you can see that for women, around about 3.5% of women over this time period had an HPV detected, but it's actually much lower for those oncogenic types. And for men, it was 11% had an HPV detected. So it's actually quite common, even if you do it as a cross-sectional analysis. Other studies have looked at what some of the risk factors are and have described it a little bit more closely. So let's just have a look at that. So this is just from 2 of those NHANES periods. And you can see there that, as we said, more common in men than women, HPV 16, which is the type most commonly found in head and neck cancers, in about 1.8% of men and 0.3% of women. And that it was associated with smoking. We know that smoking's not great for helping you clear HPV anywhere in your body, marijuana use, and number of oral sex partners. In Australia, some of our colleagues have undertaken a systematic review looking at how often people get new HPV infection over time. And they found 9 studies, really heterogeneous though. The range in rates of infection was very large, but most of them found a prevalence of baseline of about 7.5%. But interestingly, over a period of a year, about 5% of people got a new HPV infection in their mouth. And I will just point you to this most recent study out of Australia, conducted on people in Brisbane, who actually found a higher prevalence of 26 types of HPV in the mouth. You can see around 11%, a bit closer between males and females, but this was a different type of test. So this was a saliva test, perhaps that's more sensitive. And you can see that HPV 16 was the most common type. And the detection of that was associated with kissing and oral sex. Interestingly, 25% of people actually acquired a new oral HPV infection. So it's probably something that comes and goes and most of us never know about it. So this leads to the question for patients, when did I get this HPV? And look, nobody can say for sure, but what we do know, certainly from cervical cancer and other HPV related cancers, is that typically it takes decades between a persistent HPV infection and a cancer. We certainly know some of the immune markers of exposure in head and neck cancer patients have been detected about 30 years prior to the cancer. So it's highly likely this is an earlier HPV infection. The next question is, well, is my partner at risk? And this is, I think, quite reassuring data. So you can see here, this is comparing how much HPV DNA they find in the mouth of partners of the head and neck cancer patients. With the patients on the left, you can see they have very high rates of HPV detection. But the partners actually have rates that are very similar to that study that I just showed you, the NHANES study, and in fact tend to have lower rates. So no, it doesn't appear that they do have higher rates. This is another way of looking at that. This is an antibody that's quite strongly associated with HPV-related head and neck cancers. And you can see those blue clusters on the left side of both of those different antibody types. So for the cases, you can see that some of them have quite high numbers of antibodies. The partners are all below that dotted line, and the controls, so people who don't have head and neck cancer, are very similar. In fact, one of the controls actually did have a higher number there, but none of the partners. So really, you don't appear to have a significantly increased risk for having an HPV infection. That's probably because you've seen that infection many times, and as we said, most people clear them without any trouble. There is this statement here that maybe they could be at slightly higher risk, and this is because there are anecdotal cases of that happening, because we know that it was one of those oncogenic cancer-causing HPV types that cause the head and neck cancer. But at this point, there's no recommended way of screening for those cancers. You're already likely to have already shared and been exposed to what infections you have, and so therefore you don't need to change your sexual behaviour. One of the most useful things you can do, though, is have cervical screening if you have a female partner. In the interest of time, I won't go into this, but just to say that at the moment, unfortunately, screening is a no-go because the cancer is too rare. And you can see we'd probably have to screen about 13,000 people, even with the most promising markers that we have to find one case. I just want to finish up by talking about vaccination, and we've got really strong evidence about HPV vaccines now, having been using them for 15 years, and we know that the way they work is they prevent infection from being able to get into the basal epithelial cell, which are the target cells. And you can see that in the diagram there, that little red marker there is blocking this virus from being able to enter the cell in the first place. We also now, excitingly, know that they actually do prevent cervical cancer. We've seen population data from Sweden published last year establishing this. And we also know that they actually do work to prevent oral HPV. We've got this from both individually randomized trial data at the top, you can see around about 90% effective. From a community randomized trial, around about 82% effective, and targeted studies in different vaccinated populations. And I particularly like this one at the bottom here, which actually looked at tonsillectomy patients. And when they looked at their tonsils, found that vaccinated people, they very rarely found that HPV-16, but in young people in the UK who weren't vaccinated, they found a much higher rate and evidence of herd protection in males. And this is actually really exciting because we know that with 80% vaccine coverage in females and males, like we have in Australia, we're likely to eliminate circulation of oncogenic HPV, and that will mean that our children won't have oral HPV infections with these cancer-causing types. So, should we be vaccinating our patients, their partners and families? Unfortunately, on first principles, there's a low likelihood of benefit, and that's because the patient already has persistent HPV infection, and vaccination unfortunately doesn't treat that. It's preventative in nature. Now, the vaccine is sometimes used for women who've had cervical disease found at screening, and that's because in that case we know there's precancerous lesions that can reoccur if they're re-exposed to HPV, but unfortunately in head and neck at the moment we don't know of a similar precancerous lesion that we're trying to find and prevent recurrence. The partner is likely already to have been infected and most likely to be cleared and immune. Vaccination would, however, prevent new infection, or if they had a change of partner, exposure to a new type. Other household members shouldn't be considered at risk through casual contact, but if they're in the eligible age range for vaccination, and that obviously the target program is young children, the vaccine is free up to the age of 19 years, and I would suggest that it's a great way to become a vaccine advocate. We certainly need all the support we can get. The downside of vaccination, of course, is the cost, so it's not funded if you're over the age of 19. In fact, you'll get a sore arm, and I think I've tried to emphasise that there's probably a low likelihood of absolute benefit. So in summary, I've stolen this nice graphic from this article you can see on the left here, which is available online, that I think it very much reflects some of the things that you heard earlier, but emphasising that it's common. Unfortunately, we don't know in whom it's going to persist. Most of the time it clears up on its own. Partners are probably not at a high risk of HPV infection, and at the moment no change in sexual practice is recommended for patients and their current partners, and unfortunately we don't have screening available as of yet. And that's it from me. I hope some of that has been somewhat useful in your future discussions.
Yeah, that was fantastic. Thank you, Bas. That was a very clear talk. The next presenter is Dr. Maria. She's the head of clinical psychology department at the Peter MacCallum Centre in Melbourne. And she also is a research fellow at the University of Melbourne. Looking forward to your talk.
Thank you. Let me just load it up. Thank you to Lachlan and David and the VCCC for inviting me to present to you today. In my chat, what I'm hoping to do, and some has already been covered by earlier presenters as well, but talk a little bit about the importance of sexual health, some of the sexual difficulties experienced by head and neck cancer patients, and some of the psychosocial strategies that our medical teams can put in place, and then we'll look at some of the specific psychological interventions that can also be used to improve sexual functioning in head and neck patients. Sexual health is important to all of us. It's an integral part of our quality of life. It's more than sexual intercourse. It's about intimacy, our identity, our body image, expression. It's that feeling of connection and bonding and pleasure and fun. And for some, it's about procreation. It really impacts on our psychological well-being, stress relief, and it's a form of expressing care to those that we love. For head and neck patients, the treatment and the cancer itself has, as we've heard from Julie and some of the patients, huge consequences. It could create severe disfigurement, scars, stomas. It creates communication difficulties, functional difficulties with talking, swallowing, communicating. For example, if one loses a part of their mouth, their lips or their tongue, it's very difficult to kiss. It's very difficult to feel sexually aroused. It's very difficult to have oral sex. 30 to 50% of head and neck patients experience substantial sexual health problems, erectile difficulties, decreased libido, body image. As we've heard from Lachlan and our other presenters, people with HPV positive cancers also experience fears of rejections, fears of disease transmission, and a diminished sexual interest. The sexuality problems peak post-treatment, but they can be ongoing and last a lot longer and impact on mood and quality of life. In addition to cancer impacting on our sexual functioning and its treatment, lots of other things impact also on our sexual health, our interpersonal relationships, whether there's discord in our relationships or whether there's trust, how we communicate, other psychological factors, and as we've heard also earlier, depression and anxiety, and huge mental health problems for the head and neck population, stigma, cognitions and ruminations, social factors and cultural factors such as religion and cultural beliefs and social norms impact the way, impact our sexual functioning. Head and neck cancer patients really identify that sexual health is a concern for them, and they would really like their medical oncologists and their treating teams to talk about sex, to let them know what to expect throughout their cancer treatments, to provide practical information and reassurance that this is normal and other cancer patients experience these things as well. But as we've heard through Lachlan's presentation, we hardly ever do it. We don't talk to our patients about their sexual needs, and clinicians don't do it because they feel inadequately trained, they don't know what to do, where to refer, they don't have time, they don't have privacy, they believe sometimes it's someone else's job to do it. And we also make assumptions. People are too sick, too old to be talking about sex, and sometimes they don't want to make the patient feel uncomfortable about talking about their sex lives. Patients don't bring it up because they think, well, if the clinician hasn't brought it up, maybe there's nothing we can do about it. Maybe this isn't important. They don't bring it up because they're embarrassed and they don't want to make the clinicians feel uncomfortable. The ASCO guidelines indicate that it's essential. It's essential for the psychosocial care to begin with the medical team. It's essential that we ask about sexual health, not just once, but throughout the cancer experience and treatment, at the beginning, during treatment, after treatment. Sometimes it's hard to find the words, but it might be as simple as, in the last month or so, have you had difficulties with loss of interest? Can you tell me about how the cancer and its treatment's impacting on your intimacy and your relationships at the moment? Is there anything else that we can do, or anything you'd like me to know about your sexual intimacy? If these questions are too hard, there are also some screening tools that people can use to gain this information. For people with HPV positive cancer, as we've heard, again, they have more questions. They want to know how, when, and from whom did I get HPV? How do I avoid transmitting it? What do I tell my partner? And it's important that clinicians are prepared and have some of these answers. The PLISSIT model is a framework, it's an old framework that helps clinicians just formulate how they can go about asking about sexual health in the clinical consultation. And firstly, you invite someone and seek permission to see if it's okay to talk about sexual health. So you might say something like, we're going to review a lot of things today, but I'm also going to ask you about your sexual health. Is that okay by you? So you give patients permission, and they can opt out if they don't want to talk about their sex lives with you. Normalizing the experience. In my experience, I've seen many patients that go through this treatment and it impacts on their intimate relationships and their sex lives. So you're providing a normal framework about it. If there are some things that you're comfortable about providing practical information about, such as some of that information about HPV, but it might be about lubricants, it might be about where to get further information. It might be providing practical information such as the Cancer Council Sexual Intimacy Booklet. And when you do feel uncomfortable, you can offer a stepped up intervention to refer them to their GPs or the psychosocial oncology department or a sexologist or someone else that can provide more information about sexual health needs. When people do come to a psychologist, the first thing that we work on when we talk about sexual health is communication. What we know in the literature, and there hasn't been much literature in the head and neck population, so a lot of it comes from breast and other kind of cancers, but also the general population. What we do know is that open communication, joint resolution, transparent communication improves sexual functioning and intimacy, whereas communication that's silencing, where we avoid topics that's about demand and withdrawal, it has negative impacts on sexual health and relationships. So when we work with patients and their communication and their partners, we talk about the strengths of their sex lives and their communication, but we acknowledge the losses. Sometimes some things may never be the same again, and it's important to give people the space to grieve that. We encourage people to have an open discussion. We encourage them to talk about reassuring one another and showing commitment and love in the relationship, and then also talking about what's vulnerable and teaching them how to listen, validate and reflect. Rather, sometimes when people talk about sexual communication, it often feels like a blaming game. So it's important to teach people to listen and validate and reflect. So basic communication training. Another strategy in psychosocial oncology that we use a lot with sexual dysfunction and sexual relationships is cognitive behavior therapy. And cognitive behavior therapy looks at the behaviors and the thoughts that interfere with one's sexual functioning. So if one believes through their surgery and their treatment that they are just undesirable, that they're unlovable and undesirable, this will have physical consequences in their body. They'll feel nausea, maybe body aches, they'll feel sad and grieve, but what will their behavior be? They will probably withdraw from their partner. They probably won't even hold hands with the partner. They probably might not make an effort to, to look as best as they can, or to feel sexually attractive. So then that will reinforce that I'm undesirable. So CBT explores, identifies these cognitions that may be about performance or maybe about failure of having sex, and tries to change them by offering relaxation training, finding alternatives, and working on accepting of the way things are and how we can make them better in the moment. In the literature, we know that CBT is very useful for arousal disorders, anxiety, depression, becoming and developing positive attitude towards sex. Mindfulness is another intervention that's making the scene in the cancer literature as assisting with sexual health problems. Mindfulness is about paying attention on purpose in a particular way, where you really learn to be mindful, and you learn meditation techniques, you learn to tune into your body and emotions, because one of the biggest things that distracts people from a sexual relationship is the chatter that's in their head. So what we've seen in the cancer literature, that mindfulness does provide, improve domains of desire, lubrication, orgasm, arousal, sexual satisfaction, and it decreases the sexual distress. Again, this research has not been replicated in head and neck patients. And one of our main interventions that we have is a couple-based psychological therapy, so couple therapy or couple counselling. In these kind of interventions, the therapist and the couple work together. They do it as they do some communication, they set some goals, they learn problem solving and negotiating together, and a lot of these couple therapies include sensate focus or sexual touching exercises, which initially begin by basically exposing yourself again to touch in a different way, and initially kind of avoiding genitals and avoiding sex and building up to all that kind of stuff later on, but it's really becoming familiar again with touch. And we also look at identifying the things, the thoughts again that are interfering in sexual relationships and with your cognitions, but also broadening that concept of what sex is in a relationship and what sexual intimacy is, and exploring these kind of options with the couple. Couple interventions show great improvements in sexual quality of life, sexual functioning, sexual image and satisfaction, as well as sexual confidence and well-being. There are many different services that people can refer patients to, including psychologists for that couple counselling, but there's sexologists, there's sexual health services, but there's Relationships Australia, and at Peter Mac we also have the psycho-oncology department. And there are many resources as well for different ages that people may want to refer patients to, or give patients information to make choices about their sexual health. Thank you.
So thank you so much. It was fantastic. I now would like to invite Nadia, the CEO of Head and Neck Cancer Australia, to give a quick overview of what this charity does. Thank you so much.
Thanks, Jasper. I'll just share my screen. Now, I'm conscious that the session has run over time, so I have actually offered to do my slides in a couple of minutes. So this is going to be a very quick overview, but thank you, Jasper, for giving us the opportunity. I'm the CEO of Head and Neck Cancer Australia. We're a national not-for-profit organisation launched in 2016. So you can think of us like Ovarian Cancer Australia or Prostate Cancer Foundation. We're the first national not-for-profit organisation to be launched in Australia specifically for people who have head and neck cancer. And this was just a very good opportunity for us to make sure that if anyone's joining the workshop today is aware of us and has an understanding of the resources that are available on our website and how they were developed. So our charity was founded by head and neck cancer clinicians who saw firsthand every day the profound impact that head and neck cancer had on their patients and families and carers, and were passionate about driving change. we have developed Australia's only comprehensive library of evidence-based information and interactive resources that are dedicated to people living with head and neck cancer. Our content was developed over a 2-year period by over 70 head and neck cancer clinicians. Patients and carers were also involved in reviewing the content, and they came from both Australia and New Zealand. Our content's reviewed every 3 years. So we reach out to new clinicians and patients and carers to ensure that everything is up to date and based on the latest clinical evidence. We have a board that includes clinicians as well as patients and family members who've been touched by head and neck cancer. And we're very fortunate to have ambassadors, including Julie McCrossan, who represent patients and carers from across Australia and do a wonderful job in raising awareness of head and neck cancer nationally as well as in their local community. Sorry, there we go. Our aim is to raise awareness of head and neck cancer and to improve the quality of life of those affected through access to information and support. So what do? We provide information and support to people who've been diagnosed, and that information can cover from, before someone's diagnosed, so they're aware of the symptoms of head and neck cancer and what they may need to look out for and who they should go and see if they have concerns, treatment, and then also survivorship topics. We distribute our resources to over 60 hospitals across the country, as well as GPs and dental clinics and patient support groups. We direct patients to head and neck services, and I will definitely be putting many of the links that Maria just shared on her slides on our database, which is one of the only support databases for head and neck cancer patients in Australia that has links to different support groups and services that are available. Yesterday we actually, so one of our objectives is also to advocate for people with head and neck cancer, and yesterday I had the pleasure of being down in Melbourne and meeting with the member for Higgins, Dr. Katie Allen, to talk about head and neck cancer and the importance of raising awareness amongst GPs and dentists in particular, as well as advocating for government funding to improve patient outcomes. And I'm really pleased to say that we've been invited to present at the Parliamentary Friends of Cancer Care and Cure in Canberra, and that will be the first time head and neck cancer has been given a voice, or patients have been given a voice in Canberra to talk about, the sometimes devastating effects that head and neck cancer can have on their lives. Look, I'm going to leave it here because I know I've probably gone over my 2 minutes, but we do have a lot of resources on our website, and I would encourage anyone who hasn't had a chance to look at our website to have a look and get in contact with us if you would like us to send some resources out to you. Thanks for your time.
Thank you, Nadia. That's fantastic. I think if all the panelists can put their cameras on and unmute themselves, and I'm going to kick off with a question that Rachel just asked. She asked the question, how important is intimacy and sexual health in palliative care? She works in palliative care and wondering how she can better support her patients. I'd like to take this question.
Are you looking for a volunteer?
Oh, I'm really wondering, like...
you want a doctor?
Yeah, a doctor, for instance. How do you think this works in palliative care, and is there a further need to look beyond what we're doing currently?
Maria, did you want to?
I can start. I think sexual health is important across the lifespan, and I think this is where we need to make sure that we're bringing it up, raising it with patients, raising it with them, and they are the ones to make the choice about how important this is to them. Because it is being intimate and close all the way through to the end of life is important for people, and we need to help them find ways to express it.
Could I give a quick anecdote, because it's such a challenging topic and this is a good news story. So many of us get aspirational pneumonia because of ongoing swallowing difficulties, and I've been hospitalised twice for pneumonia. I was hospitalised on the 40th anniversary of Mardi Gras in the respiratory ward of St Vincent's, which is down this street. They gave us a private room. My partner and I dressed up. They had rainbow balloons. This is the staff. You know, I was seriously ill. I was in a sort of separate section and they all gowned up to come in, but they encouraged us to watch it on, you know, our iPhones on the SBS coverage. Now, I wasn't dying, but I was pretty unwell, and it was just fantastic to be supported, to have my partner. So if you're ever looking after me and I'm dying, I need my partner in and my cavoodle allowed for a visit.
One of my very first patients when I walked into Peter Mac in 2005. I was kind of very new to oncology, and it was an older patient, and they had a end stage, a very poor prognosis. And they came in with their husband. They were not what I was expecting, and what her goal was, she wanted to have an orgasm before she died. That was the therapeutic encounter. I didn't quite know what to do at the time, and things have changed since then.
Ask a question of either you, Julie, or Gretchen. In terms of your clinician, your doctor who's been managing your cancer, what do you want them to do? How would you like them to approach it? What would you like them to ask you about your sexual health and what you need?
You go,
thanks. I'll jump in. I think it's a very personal question. Obviously, every patient's going to have a different response, but I think it would be nice just to be asked the question in general and then leave it to the patient to see how far they want to talk about it. I think similar to Julie, no one ever approaches the topic. So, and with the support network that we're dealing with at the Royal Melbourne Hospital, there's people with very different stages of the cancer and treatment. So everyone's needs will be very different. But I think just even someone asking the question would mean a great deal to patients.
I feel we need referral pathways. And stage 4. So this group of surgeons and physics nuts who never ask the question are unlikely to move swiftly to a little bit of training, being able to help Gretchen and I if we've got a dilemma. Okay, let's be honest. So I personally think we need a network of specialist nurses, and I just pray you can help us achieve that, because there's something about the nursing world that is good at this, and the prostate cancer crew have got a pre-existing model with ongoing training and networking that we could build on. But just coming back to referral, I had an experience where I tried to raise a concern with one of my doctors, and he looked so upset that I wasn't travelling well, I stopped talking. I cared so much about him. Don't underestimate how much we don't want to upset him. So I went to my other doctor, who was a radiation oncologist, and he left the room. I was just talking about anxiety and depression. I didn't tell him about sex. And he went looking for the breast cancer radiation oncologist who he shared his rooms with, because she was good at talking, and she wasn't there, and that was the last time we ever met. So we've got a really serious issue. So solution, and because we don't want it in 5 or 10 years, this translation of research taking 10 years is outrageous. We don't live a long time, a lot of us. So we need to build on the COVID Zoom experience, and we need a specialist unit. Let's have it at Peter Mac. You're good at stuff. Victoria's always led the country, let's be honest, even though I'm from New South Wales. Get yourselves a mob of Marias as part of a specialist unit that people can join through Zoom. People are doing it in other contexts, and there would be local staff who could assist them to get the digital skills if they need it. But, you know, we need the Maria. Look how Maria, you could probably talk about erectile dysfunction, couldn't you? May I make one other quick thing I've learned about my mostly male colleagues? And that is, I've produced 2 books on patient recovery stories with clinical articles in partnership with 2 men. We've distributed over 20,000 of them by direct mail within Australia. A lot of help from Beyond 5 or Internet Cancer Australia as it is now, and also many more downloads on online. The 2 men I was working with, one in Queensland, one in the United Kingdom, who'd also had this cancer, opposed the idea of talking about HPV in the booklets, even though they're using the term epidemic. Why? It upsets the men, it upsets their wives. They don't want to talk about oral sex. The single most important thing I've heard is that 50% have a chance of HPV with one partner. You've got to get that message out there so people feel free to talk. And the other one is, someone used the expression passionate kissing. The other is deep kissing. People don't mind thinking they might have got something from deep kissing. But the only way I could get HPV into one of my little booklets was to get a surgeon to talk about it, we had a photo of him in a white coat, because that made people think at least it was medical. So the taboo around oral sex, even though we all love Michael Douglas and thinking about oral sex with his wife, who didn't? That's a joke. I know you're not allowed to joke in cancer, but you've seen the wonderful talk Michael Douglas gave with Catherine Zeta-Jones in the room and a dozen red roses, and everyone's thinking of oral sex with Catherine Zeta-Jones when in fact he would have had sex 28 years before with someone. So disappointing. But oh yes, oral sex. I talked about it at a Cancer Council fundraiser in Tasmania, just to be open about it, because I was a non-drinker and a non-smoker, and I think that delayed my diagnosis because I didn't know HPV could give it to you. And I talked about it in Tasmania. There were 300 people in the room. I could have had a pin drop. This is at a Cancer Council event. They were so uncomfortable. And I just said, I am not the only person in Tasmania today who's had oral sex. Because I've got the gift of humour, they laughed and we had a bit of relief. But people are so tense. So a lot of the patients are tense. And a lot of the clinicians are tense. That's why we reach for the nurses. I don't know if you want to comment, Gretchen.
I think it does really need to be normalised, in the conversation. And I think, all excellent talks today. One thing I have found is that, the patients who I did enrol on our previous study, it's really about giving patients permission to talk about their sexual health and intimacy problems. And I think that sort of model of permission extends across many different facets of the challenges that patients may have as a consequence of what is essentially very brutal treatment. Those are other things such as emotional distress, as you've touched on today, Julie, fear of cancer recurrence. Those things are really important that, the patients have a voice and feel that they can go to their doctor to talk about those things. I 100% agree with you that I think that this really, these kind of late survivorship issues really lend themselves to specialist nursing, but also, there are other really well-trained allied health staff, such as, the speech therapists, I think would also be, really fantastic specialists to get involved in some of these other issues as well.
But you need clear role allocation within your teams or nobody does it. It's as simple as that. And you need to give people time. I could tell you more about my radiation therapy experience, but I think why didn't they respond to me sweating and red in the face? And I actually asked for help. I actually asked for help for 4 days and they didn't give it to me. They were good people. Another bunker had broken down. There were so many people in the waiting room. They didn't have time to deal with me and it didn't appear to be anybody's job. And Lachlan, the one thing I think we've got to mention is radiation people, because, I'm so pro-radiation. Look at me. I'm not scarred and I can still work professionally. But I couldn't speak for weeks. I could literally not speak. So when the trauma really hit, I had a counsellor, but I had to stop going to the psychologist at the team because I couldn't speak. I think Maria, I don't know if you'd want to comment on that, but this loss of speech at a time of trauma, I assume it reinforces the difficulty.
You're on mute.
Yeah, it does reinforce difficulties and isolation and aloneness when you can't communicate your needs and yeah. So there are other ways though, and we're getting better. There's typing, there's other ways to try not to feel so isolated. But Sometimes the treatment is so isolating, and the depth of what people go through, I don't think they suffer sometimes alone.
And I think for some of us, by the time we're well enough to think about it again, because it takes a while, I assume I'm not alone in that, we're seeing Lachlan and our surgeon David less. We're not seeing you so much. It tends to be these quicker things. You anaesthetize me, look down my nose, it's not there, out you go. So you're not in that intense relationship where if you don't have someone to refer me to, I don't think you're going to have time to talk to me because you've booked me up with 15-minute appointments.
Yeah, I think that's a very valid point. And, I guess one thing I usually tell my patients is that, when you're going through treatment, you're getting a lot of attention on a daily basis from, multiple people within the department. And I actually think that certainly those weeks after treatment is really a high risk time for distress, because you've got all this attention and then it's sort of, oh, you finished, we'll see you in a week, and then maybe another week after that. And I think that, again, it's patients need to know that they can reach out to us when they are feeling that degree of distress. But, it is challenging, as you say, fitting all these issues in. And that's why I think probably while they should be acknowledged and discussed, in ours, there are other specialists who can address those issues probably better than what the oncologist can.
So Lachlan and David, from the fantastic presentations that we've had today and just learning about how important sexual health and intimacy is, and particularly from getting the personal front side of it as well, what plans do you have or would you like to see coming out of this workshop that could lead to more consideration of sexual health issues at the VCCC, for example?
David, did you want me to?
Yes, I could start if you like, Lachlan. So from my perspective, I'm very supportive of the whole process of this meeting, and I've learned a lot from it. There are many patients who don't want to approach these questions and deal with them. And so you look for a clue or a cue from a patient that they want to open up these areas. And I think as an educational person and a teacher, I think we need to extend our multidisciplinary team learning to cover this area. So that's within the colleges, so that we bring people together, trainees, young surgeons, young radiation oncologists, allied health professionals, and we have a session within our teams talking about all of these issues. How do you approach patients to allow them, give them permission to open up? And equally, how do you allow patients to keep their privacy? So I think that we need to develop, and if we had a session within the VCCC Parkville that was orientated towards cancer specialists and their trainees, including Maria, including our virologists, then we could build the knowledge base and we could build the confidence in the doctors to be able to tackle these issues.
I'd just like to add on to that. I think, I guess what I'd like to see, I think there are some, maybe some non-confrontational ways that that we could assess whether these issues are important, and that might be things like doing some screening before patients come in to see us, like with a patient concerns inventory, and those patients who select, either sexual health concerns or intimacy concerns. That kind of gives them the opportunity to let you know that that's something that they would like to discuss. I think from an organisational perspective, I think I really think along the lines that of the comments that particularly Julie's made today, I think we really need to put some focus in advance to the advocacy work around having a specific head and neck late effects clinic. And what we also really need, I think, is a champion of the nurses to lead, I guess, is in terms of advocacy, and also be maybe one of the pioneers in terms of this is what, from their perspective, what they think is needed in this, head and neck clinic, and really lead that process. That would be my comments.
Could I make a quick comment, Jana? I just want to say something about the word sexual dysfunction. I just think it's unappealing.
Mm.
And who wants to go to a sexual dysfunction clinic? And no offense, guys and girls, but I can suddenly see a little plaque, sexual dysfunction clinic. And who wants to be sitting outside? After all, you put otolaryngology, and the fact that I can pronounce it shows you I spent 20 years on the ABC. Well, no one knows what it means. So call it sexual issues.
Yep.
Kissing, call it kissing. Call it kissing and hugging. Have you returned to kissing and hugging with your partner? If you put sexual health, they'll think they need a shower. So consult Maria and her kind for how to refer. What language use? And if I could really say, this is actually a skilled area. I applaud David and Lachlan, you doing generalised information. I applaud you consulting the nurses, but bring in the breast cancer and prostate nurses, talk to them about the training and work that they do to have peer support. But in the end, there are times when we need expertise, and there's insufficient clinical psychologists. If I live long enough, and I won't, I think you'll have specialist head and neck nurses, because HPV is going to rocket up. The more of us middle class people are going to have this freaky treatment, and we're going to ask for more. We expect more. And you will have to have specialist nurses, and then they will triage us, and those most desperate will be sent to Maria. But you need more Marias, and they need a career path. I've been told the nurses need a career path and the psychologists need a career path because there aren't enough of us to make them commit to the learning our special needs. And that's why I was wondering if you could hook us in with lung cancer or some other cancers, and Maria would know better than me, but where there's some crossover. Because it's not, I had a referral before I lost my voice to a psychologist in my team, and she helped me with fear of death. Now, no offense, David, but you probably don't like talking about death with them. Not at length. It's all right. You're trying to make us live. I want you to go full on. And same with Lachlan. But the Maria lookalike, we could talk about death, and she was great.
Thanks very much, Julie. Really great points. Rachel, I just want to also just quickly throw to you, just following on from the work that you've done around the psychosocial issues, are you sort of aware of, or what tools or interventions or language or material that we should be thinking about also looking at in our consultations?
Yeah, thanks, Jane. So I've actually been working with Julie on a project. So we've been I've just had we've been doing some Think Aloud interviews with the resource that I developed at the end of my PhD. So we're hoping in the not too distant future that that's something that will be available. So the idea is that that's something that clinicians can use in their consultation with the patients to talk through some of those questions that Julia covered as well, about what questions they have about HPV, and especially, how long it takes to develop, whether their partners are at risk of transmission, whether they should get the, details about the HPV vaccination and all those sorts of questions. So we're hoping that that's something that's going to be really useful going forward once we've kind of finished, once we get some funding to evaluate it properly after the Think Aloud interviews.
Thanks, Rachel. And Julia, can I just throw a quick question to you too, please? Given the vaccine and what's happening, in how many years' time can we expect to see the HPV-related head and neck cancer numbers go down?
No, I'm sorry, we still have to wait quite a while. The difficulty is, of course, as we just heard, that it takes decades probably between infection and cancer developing. So I know the projections, certainly in the US, where it wouldn't be till about 2060 when we start to see that decline. And of course, even though many head and neck cancer patients are young, the median age is still, in the 60s. So it means that for cervical cancer, the median age is lower than that. So we will probably see the impact on cervical cancer before head and neck cancers, unfortunately. But I think, on reflection, I think that it is still really important for us all to use the head and neck cancer story to encourage parents to vaccinate their kids. It's certainly a great gift that you can give your children to protect them against cancer. So why wouldn't you?
Jane, could I just say, I know we've got to finish, but that's such an important point because I do a lot of talking about this. And I think, you know, I said at the beginning, I want you to band together to get the resources to help us. In our advocacy to get those resources, one of the challenges is they think, oh, the vaccine will sort it out. And you have to tell them it's decades and decades. There's a lot of us who are going to be fronting David and Lachlan. You'll never be able to retire, gentlemen. We're going to need you and your teams. And the other thing is, I tried to introduce it with that young mother at the beginning. Correct me if I'm wrong, David and Lachlan, but there's a concerning emergence of young women getting this cancer, and I don't think we're 100% sure yet why. So again, those young women, and there'll be some men, boys, younger men as well, they're going to be with us long beyond our lives. So I think that's so important to get across to the Minister Hunts of the world that the vaccine isn't fixing it yet.
Lachlan's just posted a comment in the chat saying oropharyngeal cancer is estimated to be the third most common cancer in men aged 55 to 69 in the US by 2045. So, yes.
And I think
that's
a
major cause of death of Aboriginal men from cancer.
Yeah.
I mean, I think that's a really important point. This, you know, the incidence is just going to increase from here. And I think addressing a lot of the unmet needs that this patient cohort have is really important because there's going to be a tidal wave of patients coming through. And if we don't get a handle on what their needs are, then, we're not early on anymore. We're, in the middle of it. And, we really need some planning for how to support these patients as they're coming through. I'm not sure whether Julia has any comments about whether we're expecting a similar trajectory in Australia or whether that data is even available, but certainly, it's concerning that this is going to be a bigger problem.
Yeah, look, I certainly had a quick look at the latest data when I was preparing for my talk, and I think the most recently available data does suggest that it's still going up. Certainly in males, we're definitely still seeing much more pronounced than females. Of course, our cancer incidence data is a little bit behind, but the most recent data is definitely still increasing, yeah.
Look, I'm just aware of the time. We've gone about 15 minutes over, and I know David and Lachlan, you just want to sum up at the end. Just before we do finish this discussion, are there any of the speakers on the panel, as I just gaze across you all, do you have any final comments that you'd just like to raise or mention? Just pop up your hand.
I would just like to say we were really fortunate to be offered some funding from the WECMICS, the Western and Central Integrated Cancer Service in Melbourne, and I probably missed out a word in that acronym, to host 4 head and neck cancer webinars in 2021. Our first one's going to be on physiotherapy and lymphedema after head and neck cancer treatment, and that's happening in early May, where we had some topics in mind. But after this session, I really think perhaps one that we can put on is about sexual health and intimacy. And so perhaps, Maria, we can have a conversation later about, potentially presenting at that. And I'd also just say, as I mentioned in my very quick slide presentation, we do have an opportunity to raise some of these issues when we have our opportunity to present at the Parliamentary Friends Group in Canberra, and that's likely to be in late May or early June. That's the first chance head and neck cancer patients have ever had to have a voice in Canberra, and we would be delighted to have further conversations to make sure that what we're asking for is what everyone feels that head and neck cancer patients need. Obviously the lists are very long and there's so many things that we know, whether it's specialist nurses, whether it's resources to help Indigenous Australians, psychosocial support, dental care. And we'd be really grateful to work with everybody to make sure that we're representing the areas that, are felt, to warrant that help and, to have a unified voice. So we'd be really grateful to have those conversations and to have the involvement of everyone. And also really pleased to have you know, had the opportunity to share the work that Rachel's doing with our head and neck cancer community, and they can provide feedback on that resource, and then making those resources available on our website. It's really important. We certainly don't want to be reinventing the wheel. So whatever we can link to help patients and clinicians, the better. So thank you.
Great, that's great news. Thank you very much, Nadia. Julia, I'm just going to give you one more question. A question's just popped up around adolescents are starting sexual activity as young as 13. Screening, I'm assuming it's the cervical screening, doesn't start until they're 25. Should screening start earlier?
No, is the answer to that question.
That's what I thought you'd say.
Yeah, so we now have an HPV-based screening program. And as we've just heard, HPV is unbelievably common when you first start having sex. So if we start screening all these young adolescents, we're going to be sending everybody up to have their cervix looked at by specialists unnecessarily. We know their risk of cancer is really low. It's even lower, like minutely almost absent, now that most of our young people have received the HPV vaccine. So absolutely not. Waiting till they're 25 is safe, it's effective. Most important thing to do is look after your own sexual health, teach them about chlamydia screening, and if they want to have a chat to their doctor while they're there about what symptoms would be of concern if they developed any down there, that's absolutely the most important thing they can do, not cervical screening at that age.
Thank you very much, Julia, and thank you all my fellow panellists. Just to remind that a recording of this and the presentations will be available online at the conclusion, so you'll be able to listen to it all again. But Jasper, Lachlan and David, I'm going to handball it back to you.
Lachlan, do you want to make any closing comment?
Look, I think today, you know, it's been an amazing series of talks that, you know, we've all had by very, you know, enthusiastic, engaged panelists and presenters. And I just really like to thank everyone for bringing that, you know, that level of enthusiasm from the moment that, you know, we kicked off the idea of running this symposium. And I'd like to thank, you know, the engagement from the audience. We've had, you know, we had many more attendees than I think I was initially anticipating, which I guess speaks volumes to the issue. So from my perspective, I think it's just great to see that there's such enthusiasm to, you know, to help address this unmet need and likely many others by everyone who's participated in today's symposium.
So I'm going to close the meeting and thank you to the 48 participants who are still there. It's been from my perspective, been a wonderful experience. The issue is, what are we going to do next? We'd be very happy to hear from the participants when they are invited to give their feedback on their ideas. From my perspective, I think it's a training exercise, and we've got to make sure that all the doctors, all the nurses, all the allied health professionals within our field understand that this is a problem for patients and that we need to be able to have a response to patients and give them the opportunity to express themselves and provide assistance to them.
And David, can I beg you to get together a bunch of surgeons who do the head and go and see Mr. Hunt or whoever is next and explain the link between teeth and cancer, because the level of suffering out there is appalling. And I think sometimes it's only the ENT and the maxillofacial surgeons who see the disaster 10 years later. And we're all terrified we're going to get necrosis. Everyone's constantly asking each other about, you know, the oxygen diving or whatever it is. And there's incredibly mixed evidence out there. And it's like it always washes over when I mention dentistry, just because the Australian Dental Association was so good at lobbying against the inclusion of the mouth in Medicare. It doesn't have to stay that way. And I say that as an orthodontist daughter.
Thank you, Julia. Thank you to all our speakers, all our presenters, all of the organising committee. Special thanks to Jasper and Cynthia, because without you, we wouldn't have achieved this. So thank you, everyone, and good evening.